Hello and welcome to our MyIBD Learning virtual program, IBD Medications, How Do I Choose the Right One? My name is Amber Towns and I am the Foundation's Manager of Pediatric Education and Resources. I'm very excited to be moderating tonight's program. When it comes to deciding the right IBD medication, there are a lot of factors to consider. Tonight, we'll hear from IBD experts on how to choose, start, and even switch medications, and how we can best address these concerns with our physicians. In order to make the program more interactive and find out how much you've learned tonight, we'll be asking 2 questions via a poll on your screen now. The first, what do physicians consider the most important factor for determining a course of IBD treatment? And then the second will be which type of IBD medications are most commonly prescribed for the pediatric population. I'll give everyone a few seconds to make their selections, and then at the end of this presentation, we'll ask these 2 questions again and see how much the group has learned. All right, perfect. Thank you for your participation. Looks like most people selected disease activity and severity for the first question. And then for the second question, it looks like biologic and small molecules was selected. So let's listen in and follow the presentation to learn more. And on behalf of the Crohn's and Colitis Foundation, thank you all so much for joining. Next slide. Perfect. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professionals. This program will be recorded and posted on the MyIBD Learning website, www.crohnscolitisfoundation.org/MyIBD Learning, and everyone who registered for the program will receive a link with the recording next week. We do want this to be as interactive and engaging for you, so we will encourage you to submit your questions through the Q&A box, which can be found at the lower part of your screen. Following our expert discussions, I will moderate a Q&A session with all of our panelists, and we'll address as many questions as we can at that time. Tonight, we have the opportunity to hear from 2 IBD-focused gastroenterologists. Our first presenter will be Dr. Jose Aguirre. Dr. Aguirre is an assistant professor in the Division of Gastroenterology and Hematology, Department of Internal Medicine at the University of Texas Medical Branch, Galveston. He is a member of the Crohn's and Colitis Foundation's National Scientific Advisory Committee and serves as chair for the Patient and Provider Education Subcommittee of the South Texas Chapter's Healthcare Professional Engagement Committee. Our second presenter is Dr. Lara Hart. Dr. Hart is a pediatric gastroenterologist at Humber River Hospital in Toronto, Canada. Her specific areas of interest include inflammatory bowel disease, endoscopy, and patient trainee education. We understand the importance of your questions and want to ensure we answer as many of your questions as possible. So tonight we have the honor of having Dr. Liliana Pereira monitoring the Q&A box. Dr. Pereira is an associate professor of medicine at the Jobian and Advizian School of Medicine at Boston University and the director of the Crohn's and Colitis program at the Boston Medical Center. Dr. Pereira's clinical interests include patient-centered multidisciplinary care for complex IBD patients and motility disorders in IBD. If you have a question for Dr. Pereira, please type it into the Q&A box. She'll do her very best to answer as many questions as she can, keeping in mind she may not be able to address every question. Following Dr. Aguirre and Dr. Hart's presentations, Dr. Pereira will join them for a live Q&A session. Listed here are our speakers' financial disclosures. And now let's get started with tonight's presentation. At this time, I'd like to welcome our first presenter, Dr. Jose Aguirre.
All right, welcome everybody, and thank you for your attendance tonight. Today I wanted to review a couple of objectives that will help us find the right IBD medication for you. We'll first start by defining both your patient's disease severity as well as their activity. We'll be able to compare treatment approaches, and we'll specifically look at top-down versus bottom-up treatments. We'll also discuss timing of starting medications, as well as special considerations that overall will help us find the right medication. Next slide. So, disease activity and severity guide most of our treatment decisions. Previously, patient-reported outcomes were the primary driver of how we made our medication decisions. Patient-reported outcomes, these previous primary measures, looked at how our patients were feeling: bleeding, diarrhea, fever, or abdominal pain. As we've evolved our treatment approaches, we are also able to examine a patient's inflammatory burden. We do this both endoscopically as well as with using markers of inflammation. This includes tests like our CRP or ESR and fecal calprotectin. We also want to take into consideration a patient's disease course and try to predict their needs for hospitalization, understanding of their needs for steroids, and if they've had failure to respond to medications. Ultimately, disease impacts our functionality and quality of life, and we want to find the best medications to help us maintain that. Next slide. Disease activity. This can be considered as defined as the degree of illness at the time of evaluation. So these are back to our primary symptoms. How often are we having stool frequency? Presence of rectal bleeding? What are our findings on endoscopy? And an overall global assessment of on how well someone's doing. So of course, in remission, we anticipate having good control and normal stool frequency without rectal bleeding, normal or improved endoscopic findings, and overall health. Next slide. Severity provides prognostic markers. This basically helps us interpret and helps us predict what an overall patient's course may look like. So as I mentioned, this helps us identify prognosis, anticipate complications, and hopefully prevent the need for surgery. This table highlights some of the poor prognostic factors in ulcerative colitis, and some of these factors include being diagnosed at a young age, patients with extensive or pancolonic disease, patients who presented with severe disease, have been hospitalized, have high inflammatory markers, or poor nutritional status. Next slide. In summary, to reiterate, disease activity and severity guide our treatment decisions. And it's very important to be able to distinguish between disease severity and activity. Our severity, again, is our prognostic marker. It helps us predict over time the type of clinical course a patient may encounter. And their disease activity is the degree of illness at the time of evaluation. Now, patients who have moderate to severe disease will use a severity-based maintenance therapy. If we can advance the slide here. So we can have patients who have mild severity, ulcerative colitis or Crohn's disease, who are doing well clinically, have inactive disease and are in clinical remission, or they can present with their typical flare symptoms and have active disease. The same is true for moderate to severe disease. Patients can both be doing well in remission with inactive disease, or they can be presenting with flare or active disease. Next slide. This schematic highlights the traditional step-up approach in the treatment pyramid for inflammatory bowel disease. On the left, we see mild severity disease and going up in severity up the pyramid. With mild disease, we approach treatments using medications such as the 5-ASA drugs or mesalamine, sometimes antibiotics or colonic-specific steroids. As we move up to moderate disease, we use immunomodulator type drugs and or steroids. And in severe disease is where we step up to rescue medications, surgery, and our advanced therapies. And this includes our biologics and small molecule inhibitors. Next slide. Now, when approaching moderate to severe disease, there has been a shift or a reversal in this pyramid. In moderate to severe disease, we prefer using a top-down approach where we start off with our advanced therapies. This is our biologics or small molecule inhibitors, plus or minus immunomodulators and steroids early in disease. And we try to reserve surgery for later in disease. Next slide. The overview of treatments, I like to break these up into two different portions. First are treatments to induce remission, and this is basically to have remission of symptoms, alleviation of symptoms. And then maintenance of remission, this would be to prevent flares. On the left side, under induction of remission, we use medications like the 5-ASA drugs, immune modifying drugs, and advanced therapies, just similarly like we would in maintenance of disease. I have highlighted corticosteroid use for the induction for the induction of disease. This is highlighted because corticosteroids are very commonly used for induction. However, they should not be used for maintenance therapy. The mainstay of maintenance therapy will be our 5-ASA drugs, immune modifying drugs, and advanced therapies. Next slide. So how do we select our advanced therapies for treatment once we've decided a patient has moderate to severe disease? Well, there are multiple factors that we have to put that we combine with patient preferences to ultimately determine what is the right medication. So severity and urgency, this really helps us determine timing, how quickly patients need medications. We also want to discuss if patients have received advanced therapies before versus the medications they may have already been exposed to. Treatment failures also present another hurdle when choosing the right therapy. And then we have multiple special scenarios, and this includes extraintestinal manifestations such as skin or joint disease, pregnancy concerns, safety profiles, patients with perianal Crohn's disease, and ultimately our patient preferences. Next slide. So first, looking at severity and urgency. If we have patients who have moderate to severe inflammatory bowel disease and are acutely ill, so have disease activity currently, these patients are at high risk for complication, deterioration, and need rapid therapies or need timely therapy. In a patient like this, we'd first want to start off with determining if they've received advanced therapies before or not. In patients who have not received advanced therapies, we typically lean more towards medications like infliximab and then one of our JAK inhibitors if it's needed. Now, if patients have previously been exposed to advanced therapies, if they were exposed to infliximab, well, then we would naturally shift more towards one of our JAK inhibitors. Now, if patients have had no anti-TNF therapy, then we revert back to infliximab. Next slide. In a different scenario, a patient with moderate to severe inflammatory bowel disease who is clinically stable. They are possibly in remission or presenting without symptoms and don't need a rapid medication. Again, we look at to see if patients have had advanced therapies before or not. Now, a really important point that I'd love to stress here is that most of our advanced therapies are good options for Crohn's disease and for ulcerative colitis. And we really can't choose too wrong here. We just need to make sure that patients are on medications that will take care of their disease. In Crohn's disease, if we did have to favor, we'd favor more towards our IL-12, IL-23 inhibitors in patients who are treatment naive. In ulcerative colitis, we'd favor more of our anti-integrins in patients who are therapy naive. Now, in a clinically stable patient who's been exposed to previous therapies, if they were exposed to infliximab in the past, well, then we'd likely recommend or lean towards JAK inhibitors. If there has been no prior anti-TNF therapy, then most therapies that we have in the advanced therapies are good options for patients. Next slide. Now, I'd like to also review some special scenarios that can also help shift our thinking in the treatment of moderate to severe inflammatory bowel disease. For patients who have extraintestinal manifestations such as skin, joint, rheumatological diseases, we do favor medications like the anti-TNF drugs, the JAK inhibitors, or any of the anti-IL-12/23 medications because we can effectively hit two birds with one stone. Now, patients who have concerns for pregnancy, planning for pregnancy, or are pregnant, most of our biologics are safe medications and we continue them through pregnancies. At this time, we do try to avoid JAK inhibitors in patients who are thinking of becoming pregnant or need new medications during pregnancy. We can also look at safety profile to help us determine which medications would be the right medications for us. If we are strictly looking at safety profile, the anti-integrins and IL-12, IL-23 inhibitors are very safe medications, but overall, all of the biological medications are safe medications. Lastly, patients with perianal disease, we do tend to lean on our anti-TNF drugs. So a patient's severity and their acuity, combined with factors if they've been exposed to advanced therapies or not, special scenarios, all of these factors come together so we can help to help frame and integrate our patient's preferences to find the right drug for you. Next slide. I'll now hand over to Dr. Hart, and she'll provide us a pediatric perspective.
Thank you very much. I'm very excited to be here today. I want to go through 3 different factors with you, or 3 different objectives. So we'll look at unique factors for the younger patient population, for the pediatric patients. We'll look at best treatment options for the long term, things to consider. And then we'll discuss briefly advocating for yourself and making shared decisions with you or your child's healthcare team. Next slide, please. So unique factors for younger patients. Next slide, please. I just want to briefly speak about childhood inflammatory bowel disease as an entity of itself. So 25% of patients with inflammatory bowel disease present before 20 years old. So they present in their childhood. 4% even present before age 5, and 18% present before age 10. So we're seeing a lot of young patients in our pediatric practices, where it used to be primarily only teenagers, and now it's affecting much younger children. Overall, for the USA and Canada, there's about 10 per 100,000 children who are diagnosed with Crohn's or colitis. So it's getting much more common and much more well known among families and among people in North America. While the most common presentation for Crohn's and colitis is still the same for children, 22% of them actually present with atypical presentations. So they may come to our offices where their main symptom is growth failure, not gaining for height or for weight. They might have anemia, so low red blood cell count, and present with very low energy. They might be presenting with perianal disease, so painful bowel movements, pain with sitting, features of actual abscesses or collections there. Or they might present with extraintestinal manifestations, such as leg rashes, joint pain, mouth sores. That might be in their main presentation as opposed to the more classic bloody diarrhea picture. There's also differences in disease when you compare children to adults. So in children, the upper GI tract is much more involved than in adults. And so for all of our pediatric patients, we do a gastroscope as well as the colonoscope. And it seems that when IBD is diagnosed in childhood, there's a higher risk for more severe disease course. And we're very thankful for the great medication options that are available now to counterbalance that. Next slide, please. So when it comes to unique factors for medications for pediatric patients, I'm sure all the adults out there might not know this, but not all the medications that are available to adults are available to children under 18. So all those different classes of medication that were just discussed, not all of them are easily accessible to children, which is very frustrating as a pediatric practitioner. In fact, most of the medications aren't even on the label for children, so we call them off-label medications. And that can become a real bugger when it comes to insurance, to coverage for the medication. And there's often times where it needs to be done as a compassionate coverage, where the drug company is thankfully able to help with the coverage for the medication, because otherwise the children don't have access to it. And a lot of the times the medication is first has research done it for the adult population, and it takes at least 5 years or more for the medications to reach the pediatric population, which is, again, quite frustrating because there's so many great medications out there, and we would love to be able to use them all. When we think about medications, we also consider that for children, although I'm sure it's also true for adults, there can definitely be needle phobias or procedural phobias, which can impact the choice of medication they want to use. And also, very importantly, and maybe I'd say we're very focused on growing, maybe hyper-focused on growing in the pediatric world, but we think about the choice of medications in relation to the timing of the diagnosis. So if a child has not finished their growing, if they're prepubertal or pubertal, then we really need to make sure their gut is in remission, that their bowel is very much healed as best as possible, because active inflammation in the bowel can impact growth. and can lead to growth stunting. So if they are a younger child, we really want to focus on healing that bowel because this is the window they have to grow, and we don't want to impact that. So we look at gains in height and weight. We're always measuring those factors. Unfortunately, when you're younger is the only chance for good bone health. So we want to make sure that they are absorbing calcium and vitamin D and able to have the strongest bones possible. And we want to look at nutritional status, as all of these are factors with growing and with, achieving your maximum adult height and being in a nutritionally well state. And having a healed bowel is your best chance for all of those. With medications, of course, we want to make sure we get kids into remission because that allows for school attendance and for quality of life. So of course, quality of life is equally important for adults as well, but we really focus on that for children. And then other medication-specific considerations. There's been a lot of research that shows that early use of biologics for severe disease types, especially for Crohn's, improves outcome. So that is using a biologic within the first 3 months of diagnosis, and we take that to heart. When it comes to really severe disease that we see with Crohn's disease, we want to try to get them onto the best medication early to improve how things go in the future. Within the realm of medications, in pediatrics, we also have exclusive enteral nutrition. So a nutritional liquid diet for induction of remission for Crohn's disease. This is particularly helpful for kids who do present with growth failure, or especially with kids who have small bowel inflammation. And the exclusive enteral nutrition can actually bring down the inflammation significantly and start healing the bowel, and allows us to avoid a course of steroids by using EEN instead. And also we try to avoid repeat courses of steroids because we know that those repeat courses can have long-term effects on the child. Next slide, please. So when you think of best treatment options for the long term, there are a number of things to consider. I'd say these apply for children and for adults as well. So thinking long term, once we get a patient on a medication, the goal is that you stay on that medication for as long as it remains effective for you. So you really want people to be thinking about which medication is the best choice for them, because we want to consider that you're on this for, quite a long time. So how often do you take the medication can be a big factor. Is it a medication you've got to take every day? Is it once a week? Is it every 4 weeks, 6 weeks, every 8 weeks? If we can have a patient on a medication every 8 weeks, that means you're only taking it 6 times a year. And for some people, that's really good for quality of life, for traveling, for going about your daily activities. We consider which route the medication is being administered. Oral medication. So for children, they can't always swallow pills. So we have to, help them with that if oral medication is the best choice for them. There's also injection versus intravenous. Often the injection route is more often than the intravenous route, but the intravenous route can require more time for it to be administered. So we've got some kids who prefer the injection. It can be only a few minutes of time. It's often more often. Versus the intravenous means they might miss school. They've got to sit for at least 3 hours to get the medication. That can affect parents' work schedule as well, but it can be less often. So we always consider the how often and which route when it comes to thinking long-term and having, thoughts about which medication works best. Then there's always the physicians like myself having to tell you about all these side effects. We don't like those talks, but we have to do it. What I really focus on with my patients, though, is there are possible side effects and there are probable side effects. And the reality is we've got to list this long list of possible side effects, but at least in pediatric patients, so for children, most of them are not probable. There's a very slight risk of any of these side effects happening to the point where, yes, we have to mention them, but the majority of patients don't get those side effects. Of course, though, the side effects can sound scary, even if I'm telling you, no, you're not going to get this, but I have to tell you anyways. So we definitely consider whether, what are the side effects that could be impacting your medication choice. And then it always comes down to risk and benefit. What is the acceptable small risk that you can take with a medication in comparison to the benefits, which is, the effective healing of the bowel? So at this point, when, to get a patient into remission, we don't want just the clinical symptoms to be gone. We want to actually heal the bowel. So it's called mucosal healing. And luckily, we have a lot of medications that are very effective at healing the bowel. But with any medication, we got to consider, those benefits of effectiveness compared to the risks that come with it. Next slide, please. So let's just be a little bit more specific. We've moved away from using medications like immunomodulators as monotherapy, so as the only medication. These immunomodulators, you might have heard of Imuran, methotrexate. Those ones need to be taken quite often, and they have lots of side effects and risks. So those are considered the older medications. And thankfully, we have more effective medications, which albeit a little bit newer, that have much better benefits outweighing the risks and are very effective. So most patients now in pediatrics, over 50% are on biologics or small molecules, where the benefits are that they are effective in getting patients into remission and keeping them in remission. They are effective at healing the bowel, which brings it back to a normal appearance. And that's really important for getting people back to feeling well and living life as they want to. Next slide, please. So of course, when it comes to treatment decisions, you also want to advocate for yourself and make shared decisions with your healthcare team. Next slide. So advocating for yourself, if it's a child listening in, or advocating for your child, there's a number of questions that you can think about. So one of those is the patient and doctor relationship. Is it a good fit? Do you feel like you jive with your physician? Do you feel like you're able to talk to your physician? Do you feel comfortable going to the appointments? And then, is your child comfortable speaking about decisions or plans? So you don't expect a child in the first time that we're meeting them to feel comfortable speaking up. But the goal is that if you have a good physician-patient relationship, that your child should feel comfortable talking about the decisions and plans and saying, yes, I want this, no, I don't. And then if you don't agree with a suggestion by the physician, what do you do? So is this something that you're able to talk to your physician about? Or do you just go away and not follow, not go with the plan and not tell people? So if that's the case, I would say it's not a great patient-doctor relationship. And then that really brings it to is there a communication mismatch? So are you talking a certain way? Is your physician talking a certain way? Do you find they're able to communicate your needs? Is your physician able to listen to your needs? Is the communication working for you? Ultimately, it's a matter of trusting your gut, which comes down to advocating by having good communication between the members of the team, feeling that you have the knowledge to be able to speak and advocate for your child, and then working with your team to really, that you're both advocating for your child's best interest. Next slide, please. So it's really important when you're thinking about your choices for medication, whether it's starting a medication or changing one, that there's a shared decision model and shared goals of care. So shared decision making is the process where the patients, the caregivers, the healthcare team work together to make decisions about the treatment and the plan. And this really increases confidence in the choice of medication and treatment, in the treatment satisfaction, and the treatment adherence. But there's a number of steps involved. So information is really important. Everyone needs to have all the information. The families need to know, all the information about medications, pros, cons, benefits, risks. It's really important to have support. So you should feel comfortable sharing your treatment goals, your values, your preferences, and then asking for support as you review those options. It's important to have those thorough discussions with the healthcare team about the medication options and about what you're thinking, which ones you like or dislike. And then following through is that continuing that communication piece, making sure that there's a lot of communication when you're choosing the medication, starting the medication, while you're on the medication. Next slide, please. So Crohn's and Colitis Foundation has a great shared decision-making document, and even this really nice document that you can, worksheet that you can fill out to discuss those to discuss your treatment goals with your physician. So it includes what are your treatment goals? So is that symptom relief? Is it long-term remission? Do you want to avoid surgery? What are the treatment characteristics that are important to you? So where are you getting the medication? How is it administered? How effective it is? What makes you unsure about your choices? So, or unsure about a medication. So are you worried about being able to go to school? Is there a concern about costs, about what it's doing to the body? And then what are the next steps? So talking to the team, talking to your family doctor, talking to your family. So doing this sort of worksheet really helps with that shared decision-making and goals of care. Next slide. And that's it.
Perfect. Thank you both for great presentations, very informative. So at this time, I'd like to resubmit the 2 questions from the beginning to see how much everybody's learned. Okay, so please make your selection to the 2 questions on your screen now. Again, the first question is, what do physicians consider the most important factor for determining a course of IBD treatment? And it's followed by our second question, what type of IBD medications are most commonly prescribed for the pediatric population? Perfect. Love to see that. So the correct answer for our first question is disease activity and severity. We've learned that disease activity, meaning if you have active or inactive disease, and severity, meaning if your disease is acute or clinically stable, are the most significant factors guiding the type of treatment that's prescribed. And then for our second question regarding the most commonly prescribed medication for the pediatric population, the correct answer is biologics and small molecules. These medications are the most effective in getting patients into remission and maintaining remission, and their benefits outweigh the risks. So thank you all for taking the time to participate in those polls. And now let's direct a few questions from the audience to our expert presenters. I'd like to welcome Dr. Liliana Pereira onto camera, who's been answering questions for us in the background through the chat. If you have any questions for any of our presenters, please type it into the Q&A box, which can be found at the lower part of your screen. So I'll start with Dr. Aguirre. You had mentioned different things like JAK inhibitors and anti-TNF medications. Could you kind of explain those drugs in a little bit more detail for our audience?
Sure. So for all of the biologics are things like antibodies that are designed to bind to our inflammation markers to help reduce inflammation. And so we can do this in many ways, and our immune system is the primary, of course, source of this inflammation. And so the different biologics either use inhibitors, like our small molecule inhibitors, like the JAK inhibitors. They use inhibitors to block some of these mechanisms. Some of the biological medications use antibodies to bind to them, kind of the way your immune system would bind to a bad bug to help get rid of it. And then we also have some medications, some of the biologics that reduce some of the inflammation cells' ability to navigate into the colon to cause their damage. And so all of these different mechanisms are ways that we can target patients' inflammatory burden.
Perfect, thank you. Dr. Pereira, there were a few questions about the long-term effects of staying on a biologic. If a medication is working, is it safe to stay on long-term? Or do you think that there's a need to switch after a certain amount of time? And then Dr. Hart, if you want to weigh in on that for pediatric patients as well.
Yeah, it is. If patient is tolerating and medication is effective, currently we do keep that therapy because there is no guarantee that newer medication with a different mechanism of action will be same efficacy for that patient. And the other thing is the first biologic gives us the best result.
Is that the same for pediatric populations, Dr. Hart?
Yeah, I would agree. If a patient's on a biologic medication and it's working well for them, we do feel it is a very safe option. Again, very rare to get a side effect or adverse event from it. So if it's working well, we would keep them on it as long as possible and as long as it keeps working for them.
Perfect, thank you. And then Dr. Aguirre, how do you approach medication and treatment for Crohn's and colitis and for UC, especially in the adult population, when symptoms are not improving, but maybe those labs, those calprotectins are actually improving?
Sure. So what I really like to do for every patient has their own presentation of their symptoms. And so I always like to characterize very clearly, what does your IBD look like to you? And so that's the kind of first arm in which I look at how successfully we are in remission. We then use inflammatory markers like the CRPs and calprotectins as a non-invasive way to maybe either see how patients are responding without having to go for the colonoscopy. But ultimately, we do need a colonoscopy to show that mucosa is healing. That is our goal for therapy. Now, there are times when patients are doing clinically better. Their colonoscopy looks wonderful. And in those scenarios, if they're still having some symptoms, there might be a confounding factor contributing to it. And this is where things like stress, diet, other factors, other medications, other disease states can actually be influencing us. Some patients also over time develop irritable bowels on top of their inflammatory bowels. And so that, of course, requires, a different approach to their therapies. I think ultimately we do have the situation where sometimes inflammatory markers are not as low as we'd like to see them, We don't always have to have inflammatory markers be absent. Of course, that is a goal that we are, pushing for, but there are many times where we have to say patients are doing well and their mucosa is healing. Is it worthwhile, or is the benefit there to keep escalating therapies? And many times it's not.
Perfect. And then Dr. Hart, for maybe our teen, young adult patients, is it better to use an IL-23 versus a TNF due to risk of cancer, given the number of years that the patient will be on medications? I know that's a risk for patients who start out so young.
I mean, first of all, it's not easy to access our IL-23s. I can't speak for the US, but in Canada, it's quite difficult. So we don't really have that many patients on the IL-23s, and it's a much newer medication. In terms of the overall cancer risks or other risks for long term, I mean, the anti-TNF medications have such a low risk, if any risk at all. So I would say that I wouldn't necessarily have a patient on one versus the other for long-term cancer risks. And overall, for long-term risks in general, I would say that they're both very safe medications. So I wouldn't be considering risks and side effects necessarily in terms of the choice. They're again similar to what happens in the adult world. There's certain features that make anti-TNF more preferable than the IL-23s, but also in the pediatric world, the access is the biggest issue right now.
That makes sense. All right, so Dr. Aguirre and Dr. Hart, you guys can kind of tag team this question. There has been quite a few questions about JAK inhibitors. Is there any data on JAK inhibitors used in patients on blood thinners, or are blood clots still a risk? And then are they approved for kids to take as well?
Sure. So I personally have not been, using blood thinners in addition to the JAK inhibitors. The JAK inhibitors, of course, we're always concerned for modifiable risks, things like smoking, any clotting, but of course, concern for clotting risk or cardiovascular factors that happen in the adult population. But currently, I'm not using the two concurrently.
I don't have any patients on blood thinners. It's not a common thing in the pediatric population, so I wouldn't say that's something that we're considering. We do use the JAK inhibitors. Again, we haven't had access until more recently compared to the adult world, but we are using them and we're finding them quite effective with minimal, if any, side effects.
Thank you. Dr. Pereira, so many patients are recommended to take biologics, but they can impact your immune system. Are there biologics that don't suppress your immune system, or maybe not as much?
So it depends on what we are trying to achieve, right? So depending on the inflammatory burden, the disease distribution, sometimes we have to use certain more systemic biologic compared to gut specific biologic, which is the vedolizumab or anti-integrin therapy. So if patients have perianal disease, extraintestinal manifestations, those kind of situations, we have to use systemic biologics rather than gut specific.
Thank you. Dr. Yuri, just to follow up on biologics, a lot of our viewers have been told that biologics are not safe for older people. Are there safer biologics for older patients?
Yeah, so for older patients, I always like to stress that the medication that's controlling our disease is by far going to be the safest thing for us. At the end, if we have to, as Dr. Hart had alluded to, kind of what is possible and probable, we know if that we don't take care of patients' disease, that puts them at higher risk for development of colorectal cancer, for hospitalizations, morbidity, and possibly even mortality with uncontrolled disease. So I think at the end of the day, that strong benefit really outweighs a lot of those risks. Now, when I do have the conversation, I do like to talk with patients about their preferences, and so many times older patients would prefer to use safer medications, and that's where we lead towards, where I lean more towards the anti-integrins or the IL-12/23 inhibitors. But I'm very comfortable with all the biologics for that population. But that's typically where we lean towards.
That makes sense. Dr. Hart, how do you determine the severity of a child's new diagnosis of Crohn's. I'm sure you could probably tag team this with the UC as well, but kind of the severity of a new diagnosis in children.
Yeah, so we look at severity. I mean, we obviously consider their symptoms. We consider their blood work, their calprotectin, and then of course we're doing the colonoscopy and gastroscopy. And then the severity is primarily based on the findings on the endoscopy. So we're looking at whether or not, what the extent of disease is. Is it the full colon? Is it a long segment of the small intestine? We look at the, ulcers. Are they present? Are they absent? Are they deep? Are they superficial? I can't speak for every gastroenterologist, but there's times where you go into that colonoscopy, you look in that colon, you go, oh, that is yucky disease. That is not a medical term calling it yucky disease, but ultimately, that's kind of when we look at it and we think it's quite severe because there is really no area of normal, or there is, deep ulcers surrounded by pus and redness and swollen tissue. And those kids, you come out of there right away saying, let's get you on a biological, let's get this bowel healed. Because again, for that more severe disease, we want to get them on effective therapy early.
Thank you. Dr. Pereira, are there studies regarding why a particular drug works so well at the beginning of therapy, and then for whatever reason is unable to maintain that dramatic positive response?
So the studies, more than specific studies, will be the theory behind loss of response. This is called the secondary loss of response to a biologic. And it's mainly considered it could be due to development of antibodies, which increases the clearance of the drug, or it could be what we call the mechanistic escape. So somehow the disease has found a different pathway, because if you look at the inflammatory cascade, it's very complex. We are most of the time blocking one side of it, a small section of it. So there is a possibility that disease can escape and find a different pathway to keep the inflammation ongoing.
All right, Dr. Aguirre. Oh, so sorry. There is so much emphasis on getting colonoscopies to kind of check the how things are going. But some of our viewers are concerned that it might be a bad thing to be wiping out the colon so frequently. Is there kind of does it do more harm than good, especially if they're in remission, to be checking it so frequently?
Sure. So I think there are a few scenarios here. There are times that we need to be acting more proactively. And so when patients are very, very sick, we want to, of course, get them on the therapies as quickly as possible, ensure that they're working as well as they can be. And so many times we'll have, a few more endoscopies at that time. And so at that point, again, if we're preventing things like a perforation or worsening disease, hospitalization, the colonoscopy is probably one of the lower risks, one of the lower risks metrics there. Now, I always do want to make sure that a colonoscopy is going to answer some question for us. I want to guarantee to the patient that I typically tell patients at this time, I think it's time for a colonoscopy. And if I find this will be what I'll probably be recommending, and I want us to think about that before we go into this. But if I find, the alternative, this is what I'll likely be thinking, and this is what this would look like. So we can start to have that conversation early and ensure that patient is comfortable, and also that we're understanding that we're trying to do our best to limit any sort of risk to patients. And so that's at least the way that I've approached it.
Outweighing those risk and benefit factors, definitely. Dr. Pereira, we have a question from the audience asking, what is TNF failure?
So the TNF failure, there's two ways you can have no response to TNF therapy. That's called primary non-response. And then the secondary non-response that we just discussed, where that patient initially has a good response, over time they lose the response. And that could be, as I mentioned, it could be due to antibody formation, or it could be due to the mechanistic escape of the disease from that TNF-driven inflammation.
Perfect, thank you. Dr. Hart, you mentioned in your presentation needle phobia and things like that. Is there, how can young adults and children kind of deal with the fear of change of medication or a form of medication and how scary it might be for them.
That's really one of those opportunities to have a discussion with your team, and we hope again that the young adult or the child feels comfortable bringing that up with their physician. We don't want to be pushing a medication which is a route of medication that the child is really scared of, and we don't want them to be fearful if they're doing a needle once a week to have such fear and anxiety leading up to that day where they have to take their medication. So we really want to make sure that it's a good fit in terms of the medication. And if needle phobia plays a big role in that, then we consider, how frequent is the medication. There's some medications where, yes, it's a needle, but it's every 8 weeks. We consider whether, the needle option is therefore not the best option. So should we do an intravenous instead versus a needle injection? Is that more tolerated? Does a child have to give the needle to themselves? No, we can have a family member or a nurse giving a needle. So maybe that can be a positive benefit there. And then in my institution, and I would say most pediatric centers, there's child life experts that can work with the child to help overcome those fears. So we have child life experts that can help with learning how to swallow pills, learning how to tolerate needles, and they have a whole toolbox that can really help the child feel more comfortable with the needle phobia. Again, that could play a role in the grand scheme of things of having to change a medication if that really is the biggest impact. But we do want to try to, help them get over that phobia if they have chosen, an injection, for example. We want them to be comfortable taking it. So there's different ways to help manage that.
Perfect, thank you. And kind of to tag team onto exactly what you were just talking about, but a specific member of our audience, her son's doctor recommended switching from a Remicade infusion to a new injectable drug, which could be one of those choices of just how it's delivered. Right, since that you guys have kind of mentioned that staying on a drug is probably, if it's working, is probably the best route until it kind of isn't. Is there a risk from switching from the infusion route to the new injectable medication if the infusion is actually still working?
Just to clarify, is it the injection of the infliximab or is it completely switching to a different medication?
They didn't say. They just said from a Remicade infusion to a new drug that is injectable. So I'm assuming a different type of medication.
Well, I think we can address both. When patients are on the formulations, of course, many of the formulations are moving from strictly being an IV infusion to sub-Q, and so there are different protocols that we can use based on if patient starts during induction versus maintenance. And the data is pretty good for all of our maintenance switching if patients want or if insurance requires us to do so. And then for the question, if this were in regard to going from an infusion medication to then an injectable, different class, then I think we would approach that the same way we would any other medication failure. Figure out why the medication failed, and then help us select our next medication.
Thank you. I appreciate that. Dr. Geary, thoughts on probiotics? Do you recommend it in addition to your medications? We're getting a lot of chatter about that as well.
Sure. Yeah, so the probiotic issue is challenging. Our understanding of the microbiome still is not where we need it to be. And of course, that field of research is growing. I kind of take a little bit more of a minimalist approach here that if a patient is on a probiotic and doing well, I'm not about to tell a patient to stop doing that. There's plenty about this disease that we do not understand. And so since I don't know if that factor is going to change things, I really I don't have any safety reasons to tell patients to stop. If a patient asks if I should start, I'd say the same. I don't quite have the data that suggests that I should be recommending a probiotic to start with. But I do think that complementary medicine plays a strong role. And I think we really learned this from, I think, a lot of the pediatric data. We haven't, of course, had the same trials that we've had in pediatrics as we have had in adults, but supplements like turmeric were originally published in the pediatric journals for induction therapy in mild disease, and so turmeric is a very common complementary supplement that I advise for my patients. And so I think when it comes to those, we need to keep an open mind. If things are not going well, then we should probably try to address everything. But if things are going well, I'm not going to have patients stop.
That makes sense. Dr. Pereira, for older patients, maybe like in their 80s who are already on those blood thinners, is there a biologic that might be a little bit better for them for infusions?
So, I mean, any biologic, if it is infusion, simply because they are in blood thinners, we don't have any contraindication or concern that because it's given observed by either visiting nurse or they are in a infusion clinic. It's just blood thinners doesn't really play a role whether we are going to use the injectable. Maybe injectable we might have to be considered because they're doing it at home. They can have sometimes subcutaneous inflammation, like the bleeding. Other than that, there's no concern about if it is a infusion biologic that just because they're on a blood thinner. It's more for if they have any others medical problems that we have to decide which medication will be the safest, not just being on the blood thinner.
That makes sense. Thank you. And then our last question for tonight, Dr. Aguirre, Dr. Hart, you guys are both more than welcome to weigh in on this. If you are in remission, you've been in remission for quite some time, is it ever safe to come off of that biologic?
I'm happy to start with that one. So as I mentioned, the pediatric years are the only opportunity for growth to make sure that kids can reach their maximum potential adult height. It's the only opportunity, well, it's majority of the opportunity to have good bone health and have strong bones. So we really want to make sure that the gut is in remission and not have any active inflammation to allow for optimal growth, optimal bone health, optimal nutrition status. So in the pediatric world, we very much advise against going off of medications because if you flare up and if that disease becomes active again, then it could compromise those things. It could compromise your growth, your bone health, your nutrition. Of course, when they go into adult world, it's a different story, and I'll let you continue that answer then.
For the adult population, of course, this is de-escalation of therapy is a ongoing topic, one that we're collecting more and more data. I think this for sure requires a conversation with your gastroenterologist if you want to de-escalate therapy, and then de-escalation can be eventually taking off of therapy ultimately. At this point in time, approximately half of our patients who de-escalate will have a recurrence of their disease. And so, alluding to Dr. Pereira and Dr. Hart earlier, if patients are doing well and maintaining well on disease, I would hate to pull back a medication that we know has been helping, and take that risk. But I think for sure for certain subsets of populations, that conversation has become more and more prominent.
Awesome. Thank you all so much. This was a wonderful discussion. We've learned a lot. It has been a lot of helpful information for our viewers today. Thank you all for joining us. So just as our program comes to an end, on behalf of the Crohn's and Colitis Foundation, we want to encourage you to keep learning about IBD and to visit some helpful educational resources. For more information on medications, check out the IBD Medication Guide. The IBD Medication Guide allows you to filter and sort medications based on options such as disease, drug class, and preferred way of taking those medications. The IBD Health Center is there to provide information and resources for patients, caregivers, and healthcare providers about inflammatory bowel disease. They're available by phone or email, as well as live chat, currently available Monday, Tuesday, and Thursdays. And then if you're looking to connect with other patients and caregivers, the foundation offers virtual and in-person support groups. The QR code at the bottom right of your screen will help you locate a support group near you. And then when you have an unexpected or urgent need for a restroom, the Crohn's and Colitis Foundation can help. We've developed a campaign and an app to raise awareness and help patients across or have access to restrooms when they need it the most. So search for We Can't Wait on your Apple App Store or Google Play to download the app today. And then finally, to watch previous webinars and expert conversations, please visit the Crohn's and Colitis Foundation.org / MyIBD Learning. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback and it helps us plan for future programming. Thank you to our expert presenters and thank you to the IBD community for joining tonight. Have a wonderful rest of your evening.